Good afternoon. I think a few people are just still joining us, so we will get going in a minute or so. Looks like all of those people who were in the waiting room are now here, so I am very pleased to welcome you to a redevelopment update. Hope you have managed to have a bit of a rest over the summer. So quick whiz through the agenda, what we hope to cover in this session. We are recording this session, so it's important that you are happy with that, because we will be uploading a recording of this onto our website. If you are attending this and you're not a member of the Stakeholder reference group, it would be great to have you within that group. So the email address is there if you want to become a member. You are on mute, and we would ask that you submit your questions to us via the chat function to communications. You will get the opportunity to ask your question in person if that is your preference, but it's really useful for us to see them all via the chat function, because then we can group them if there are several questions on the same topic. We aim to just take around 20 minutes to go through a presentation, and that will allow you a little bit more time to ask questions at the end. If I can have the next slide, please, Holly. So yeah, just to go over the aims of this session, it is an update first and foremost. We're going to outline our options, also to explain the interim submissions, which some of you may have read about during August, and to give the latest information that we can on our timeline. And as I said, there will be an opportunity for you to ask questions. So you're probably bored of seeing me, because if you've been with us on the journey so far, you'll have seen me at many of the engagement sessions, but I am pleased that we've got Helen with us, and Helen is our Deputy Chief Executive, and she is very, very familiar with this project. So without further ado, I will hand over to you, Helen.
Thank you very much, Louise. So we're starting with this graphic, which is representing our kind of long and sometimes what feels like quite a difficult road to get to new hospital facilities. But we like to keep positive, and I like the nice kind of upbeat, sunny feel to this graphic, because we're absolutely determined that we're going to keep pushing forward and get to those great new hospital facilities as quickly as we can. If you can pull up the next slide, please, Holly. So I'm going to start by just giving you a little bit of context about the new hospital programme at a national level, because it's really important for our programme and our progress. So I guess, again, you'll be familiar with some of this, but just a quick recap. So the new hospital programme mandate is to deliver 48 new hospitals by 2030. There are different cohorts. I think there are 5 cohorts now, schemes that are already in build, a number of smaller schemes that are called agile schemes and expected to move forward quickly, 8 pathfinders, of which we are one. And the 8 pathfinders are effectively the key kind of major new schemes that are coming forward. And all of those pathfinders have had funding confirmed, although we'll come back to funding a bit later, and I'm sure in the questions. The new hospital programme is working on what's called standardisation. So with a whole range of programmes, schemes across the country, clearly there's a desire to see more standardisation, get a clearer picture about minimum standards that are expected around room sizes, number of single rooms, etc. And does clarify some new policy requirements around net zero carbon and expectations around construction methods. So there is a huge amount of work for the new hospital programme to take forward, and until that work is more developed, we find ourselves waiting really for clarification on some quite important points. We've been told to expect the at least first outputs from this work in the next couple of months. Originally it was early autumn. It looks more likely to be closer to Christmas until first outputs are available from that work. And then with that will come guidance that we and other pathfinders will need to incorporate into our plans. Equally importantly, and also equally kind of significant in terms of the scale of work required, is the new hospital programme is leading a national process to procure construction partners. So there's developing what's called a commercial strategy and engaging with the construction market to make sure that there are firms willing, ready and able to actually build new hospital schemes once they are approved. And I think it's fair to say that the new hospital programme is also spending quite a lot of time at the moment with the Treasury to clarify and secure the funding required to deliver the programme. And the current funding that they know have had confirmed isn't going to be sufficient to meet the needs of the whole programme, and therefore getting clarity around the funding for the programme overall is really key at this point. Next slide, Holly. So moving on then, and this is a bit of a recap, and I suspect quite a number of people on the call will be quite familiar, so I'm going to go relatively quickly. But as we set out in our Your Care, Your Views engagement programme, our vision is based around our 3 existing hospital sites and making sure each hospital has got a really distinct role, but work together to provide excellent hospital services for people living in West Hertfordshire, or at least our bit of West Hertfordshire. So Watford Emergency and Specialist Care, St Albans Planned Surgical Care and Cancer, and Hemel Hempstead with a focus on planned medical care and long-term conditions. All 3 sites will have an urgent care service, although the nature of that service does vary between the sites, and outpatients will be delivered from all 3 sites, but each service will not be delivered from all 3 sites. The strategy is to move to outpatient services based on 2 out of the 3 sites at specialty level, and we spent quite a lot of time earlier in the year explaining our plans and our thinking. We are committed to our 3 hospital model, and we do believe it's the quickest route to new facilities. Our plans have had significant input and are supported by our senior clinical team and service managers. And there are not plans to reconsider any other site options, as this would significantly lengthen the time for new and better facilities. Next slide, please. So these next 3 slides just put a bit more detail behind the vision for each of the 3 sites and the benefits that we're hoping to deliver if we can secure the funding for our preferred option. And they also set out here in more detail exactly which specialties and which services will be delivered from each site. So as I've already said, Hemel's focus is going to be medical specialties and long-term conditions, with the appropriate diagnostic provision to enable more one-stop clinic kind of service model delivery. So we want to make sure that patients with the most complex needs get the most streamlined care possible, and instead of asking people to attend for diagnostics and then outpatients and then follow up and perhaps onto different sites, as much as possible we want to organise services in a way that means that patients don't have to attend so often, and that when they do come, that there's a really good wraparound of the right clinicians and services to meet their needs, assess their care needs, offer treatment, etc. Moving on then to St Albans, effectively the same core concept, but the focus at St Albans is going to be surgical care and cancer. The diagnostics offer at St Albans has already been strengthened with new CT and MRI facilities as part of our COVID response and recovery, and we were fortunate to secure some funding to enable that to happen. But we've got our plans involve really building from there into a really well-developed rapid diagnostic centre, more investment in surgical services and improving our theatres at the St Albans site, relocating endoscopy from Hemel to St Albans so that endoscopy can be co-located with surgery and is a core part of the cancer diagnostic model. And again, the diagnostics will be tailored to the types of care and treatment provided on that site. If we move on to the Watford site, again, no significant changes to the service provision at Watford, but with investment in the estate, we've got really significant opportunities to transform the way we deliver care and significantly improve patient experience. So just taking one example, women's and children's services, in maternity services, we'll be looking to have specially equipped rooms that are called, I can't remember what they're called now, I think they've got a special name, but labour, delivery, recovery and postnatal care all in the same room. So instead of the current model where mothers get admitted and have to move around between different units, instead we're hoping very much to keep mum and baby in one place and for different clinicians to come to them and look after them through their labour and postnatal period wherever that's possible. But really a whole host of opportunities to improve the way services are delivered on the emergency care site, again with our preferred option, which would see 90% of new clinical build facilities on the site. I'm handing back to Louise at this point, so over to you, Louise.
Thank you, Helen. So yes, just an opportunity for me to update you on the feedback. So you know that we had, or you may know that we had an engagement running in the earlier part of this year, and we set out our plans for the configuration of our services across our 3 sites. So 2 phases, and in the second phase we gave a bit more detail on which services were going where. We were a bit concerned that people thought it was a sort of big centralisation pulling everything towards Watford. That's absolutely not the case. So we wanted to really focus in the second phase of our engagement on really what was going where, and we hope that our engagement documents do demonstrate that, and we were pleased that so many people did say that they found the documents useful. We did try to make it clear where our services were going, and they do have charts in them, so it is quite easy to follow our plans. If I could just have the next slide up so I can talk about the main themes. So the diagnostics being incorporated, which we sometimes call a one-stop shop, we were really delighted that that is something that those who responded to the survey feel strongly about, because it's something that we feel really strongly about as well. As Helen said, whether it's medical or surgical, we want to reduce unnecessary journeys, make your appointment as valuable as possible, and really boost the diagnostics to ensure that we're not asking you to go to different places for various stages of your treatment. Access, transport and parking, we know is an issue. We have been hearing that all along. We completely understand that, and we weren't surprised to see that come up as part of the feedback, and we are working on that very hard. We are about to set up some reference groups. We also have the first date for a steering group meeting around travel and access. So we are beginning to get some real wheels in motion, pardon the pun, on that one. And the thing that came through also strongly was your concerns about the quality of the environment. And again, we hear you, we completely understand that, and ourselves are very embarrassed at times about the quality of the environment that we offer you and that we offer our staff. So I think overall we were unsurprised by the feedback, although delighted, I think, that we heard so much about your interest in diagnostics being incorporated. So moving on, in response to the feedback, we will continue to work on the one-stop model. That doesn't in all cases require masses of investment in and big new shiny buildings. You know, we can do a lot already. We are not waiting for new buildings to make some of these changes. We have an ambitious change programme which starts next year, and we have already begun to look at our patient pathways. So our focus on one-stop models is currently strong and remains strong. We want to make sure that we are very clear with all of our patients that they will have access to face-to-face appointments. We heard through our engagement sessions that people were worried, if not for themselves, perhaps for friends and relatives, that they might not be able to adapt to some of our new ways of working, which are online appointments and telephone appointments. And we will maintain those ways of working because we have found that they have been very efficient for us and that they do save patients making journeys when a lot of information and advice and care can be delivered virtually. But it is going to be patient choice. We will use a co-production approach. So as we make changes to our outpatient models, we will be testing those out with members of the public, and we will be carrying out some surveys with people whose care has moved to online, so we can understand what has worked well and where we could do better. We are, as I said, working with local authority partners and travel providers. So those representatives from local authorities and travel providers will be part of our transport or travel, and access steering group. And then we will have reference groups which fit into that model. We will have a staff reference group and a public reference group. And we will let you know as soon as we have terms of reference to share with you and potential dates for those meetings. And we are, of course, pressing on with our outline business case and our submission for funding. So there is absolutely no halting in the pace from anyone within this organisation. We are working flat out to press the case for funding for new and better buildings. Thank you. You're on mute, Helen, sorry.
Sorry, everybody. So just briefly, this slide is a recap of the options that we are looking at as part of our outline business case. And we're at the point in the outline business case process, which is called the shortlist appraisal. And we have to do quite a lot of detailed work on each of these options, cost it up, and then do a cost benefit appraisal to come out with a preferred option, which is the most economically advantageous option, so the best balance of cost versus benefit, as well as identifying any other options that may be a viable way forward. And at Watford, it's on a spectrum from do minimum or business as usual, which is literally maintain the existing estate, do minimum, which is a step on from that in terms of enhanced capacity, the 2019 SOC preferred option, which saw a new clinical facility and let's call it a partial refurbishment of the Princess Michael of Kent building, and then some new options since the 2019 SOC, which would cost more but would potentially offer more benefit, up to and including 100% new clinical facilities, which would be option 6. At the moment, and based on our early work, we think that option 5, which is more than 90% new build, but retaining some of our existing buildings for clinical delivery, will be the best value option overall. And then at St Albans and Satch, we're looking at options from the 2019 strategic outline case, which in total saw about £50 million investment in those two sites. And we're looking at enhanced options from that. So what would we do if we could secure more funding on those sites? So just thought it was important to recap and share those again, particularly in the context of the recent press coverage about submissions to the new hospital programme. And that's the next slide, so if you want to bring that one up, Holly, this has been a bit confusing for people to understand how it fits in with our outline business case process. But all pathfinders were asked earlier this summer to provide an update to the new hospital programme on what could be delivered in line with the original allocation, which was 400 million in our case, probably more familiarly known locally as 350 million, but the 400 million includes inflation, what our preferred option is and what a phased version might look like. And as I've already said, our preferred option is for as much new build as possible at Watford and refurbishment at Hemel and St Albans with some new build. The submissions, we've had requests for sharing the submissions, and we're not planning to do so, largely because they're not formally a part of the outline business case process, and they're not, the financial numbers, etc., in them are not kind of finalised and fully signed off. So they're not in the public domain, and we're not alone with that. The other pathfinders are in the same position. And I think it's important to note, because there's a lot of speculation about, well, how much money have you got, and are the options too expensive, and what will you get for the money? We don't know yet. What we know is we've been told that as a minimum we should get 400 million. We are trying to make the case for investment above that level, but we don't know, and we won't know until our fully costed outline business case is submitted and approved, exactly how much funding we're going to get. Although there may be some, there may be some clues when we see the next spending review as to whether more capital funding is going to be put through into the NHS and into the programme. Next up, this is a timeline. So everything we've talked about today, but particularly the new hospital programme, work on standardisation, and commercial strategy has meant that outline business cases have been delayed. And again, we're not alone with this, that all the pathfinders are in the same position. Where business cases have been submitted, they've effectively been put on hold by the regulators. So although we'd hoped to complete our outline business case before Christmas, it's looking more likely to be the summer, so early summer of 2022. For everything to be completed, and then from there we need a contractor appointed to work with us. We need to get fully work through cost and implementation plans, working with that contractor and contractual arrangements, and then we would hope to be in a position to start what I call construction proper in 2024, by which I mean literally beginning to put the new buildings up, because we're aiming to have completed enabling works in parallel with the development of the business case, subject to funding being made available. So in this timeline, it looks to us like the new hospital facilities should be operational by 2027 or 2028 at the latest. But there are a number of moving parts in this, so we will be continuously reviewing and updating the timeline to make sure we move as quickly as we possibly can, but that we are realistic about what is likely to be possible. These next slides I'm not going to dwell on, because I suspect people who are interested will have already looked at them. So if you just want to click through them relatively quickly, Holly. So these are pictures from the planning application we made for the Watford site, and give you a sense of the scale and opportunity on the Watford site. I'm just going to ask you to pause. Actually, well, not so. The multi-storey car park, important, and will be open, we hope, by Easter at the latest, and that will be quite transformative in terms of people's experience of getting to the Watford site and not having to walk up the hill. The next slide shows you where a schematic for Mount Vernon, and I'm happy to take questions on Mount Vernon. It is a separate process, but we've got a proof of concept that demonstrates where Mount Vernon could be accommodated on the site and how it would link into new hospital facilities. This is a site plan for St Albans and shows, I know you can't really see it, but the yellow bits are refurbishment and the blue bits are bits of new build, and this again would be our preferred option for St Albans. and this is the Hemel site, and the plan for Hemel is to concentrate all the services into the Verulam building. The blue bits again are some elements of new build, and the yellow is signifying a significant refurbishment of the inside of the Verulam building to get the right clinical adjacencies and modernise the environment for the services we want to provide there.
Thank you, Helen. So, okay, so we would like to ask you if you have any questions, but before we take your questions, I do just want to alert you to a little bit of, well, homework, if you will. For those of you who've been in the SRG for some time, you know that we do occasionally set tasks, and this is one of those occasions. We're going to produce a very short film, just a quick catch up, so that people who want to understand where we are can have a very quick view. We aim to make a film of about 5 minutes, and within that we could address some very hot topics. So we are asking you, if you want to send a short question for us to consider including. So it needs to be something that is relevant to the whole community as much as you can, so not too niche, and we will probably incorporate 3 questions at the most, just to make sure that we have touched on some of the issues that we know are out there. But primarily the film is to update and look forward, and not too much looking back. So I think we should move straight to questions. It would be quite good actually to go back to look at that Mount Vernon slide, if you wouldn't mind, please, Holly, because we have had a question about Mount Vernon, which is just to understand how we could incorporate the Mount Vernon Cancer Centre. And I think with that, Helen, if you wouldn't mind, could you just touch very briefly on the difference between the cancer services provided by Mount Vernon and those that we talk about centralising at St Albans? Thank you.
Okay, thank you, Louise. So I'll start there. Cancer's quite complex care pathways, but they start in primary care, or often start in primary care with the referral from GPs for assessment and diagnostics. And that's really the primary focus of the St Albans service. Will be about rapid diagnostics and setting out initially, confirming a diagnosis and setting out initial treatment. There will also be treatments undertaken at St Albans. So we undertake cancer surgery at St Albans, but generally the slightly less complex cancer surgery, or on patients with slightly less complex needs. And that is very much the vision for St Albans, and continuing to build and develop that one-stop cancer diagnostics and treatment model. Some patients who have more complex cancer or more later stage cancers also need to have more specialised treatments, including chemotherapy and radiotherapy, etc. And those are services that are currently provided by Mount Vernon Cancer Centre on the Mount Vernon site. The clinical case for change for Mount Vernon sets out really clearly why they think those services would best be co-located onto an acute hospital site, because those patients are often really very sick, and particularly for inpatient care, it's very beneficial to have them on the same site as our full emergency care offer. But effectively, Mount Vernon operates at the more specialist end of the pathway than St Albans. In terms of location onto this site, I don't know if I move my little cursor, I don't know if you can see it, but at the front of the site here in the kind of pale greens and greys is where we hope that our new hospital facilities will get built. Plots 1 and 2, which are the slightly pinky ones in the middle here, is land that is potentially freed up, but we would expect, but not until the completion of the build and everything's happened, and we would expect to keep some of that land for future growth. And effectively this white square to the right, adjacent to the football club, is where we think the new Mount Vernon Cancer Centre could go, and potentially that build could happen at the same time as our new build, with a bit of enabling works and moving the staff restaurant and a few other things. So the picture here is the initial architect kind of design of what Mount Vernon would look like and where it would sit. And it sits, I don't know if people are familiar with the sort of green walkway through from Vicarage Road through to Thomas Sawyer Way, but Mount Vernon would sit onto that walkway, as would our new hospital. And this bridge link connects Mount Vernon into the new hospital. Now, our plans and the Mount Vernon plans are still at outline planning stage, so there is detail to work through. But our architects and technical teams have advised that they think that this is a workable solution and that we could absolutely accommodate Mount Vernon on the site alongside our new hospital facilities.
Thank you, Helen. That was a question from Anne, and I think Anne, it would be useful to know if you think that we've answered the question. I did say that we would give you the opportunity to ask questions, but I think we have actually covered that question. But do let us know either via the chat function or going on camera if you think that we need to give more information there. There's $1 million question, probably quite literally here, Helen. I'm not sure we can answer it, but we should acknowledge it nevertheless, about the probability that there will be no or minimal money from the Treasury. Have you got any comment or any insight into what the Treasury might be thinking in terms of amounts that we could get?
No is the quick answer. So I know that this is a live discussion and has been for some time. We know as a minimum that the 400 million has been earmarked for our scheme. We are making the case, we have made the case, as have the other pathfinders, to say, particularly with all the things that have changed over the last 2 years and expectations around net zero carbon and around digital, and the learning from the COVID pandemic, that really it's going to be difficult to deliver what we believe we need to deliver if we're held to that 400 million envelope. But I just don't know what the government's ultimate decision is going to be on how much capital it thinks it can put into the NHS at this point in time. And we're just going to have to make the best case we can and see what the decision is.
Thank you. I have a question from Jenny here. It's very self-explanatory, Jenny. So if I ask it for you, unless you let me know otherwise, it is about services on all of our sites and whether people will still have choice. So she says, when there are services on more than one site, will there be an attempt to give patients appointments and services on the site nearest to where they live? So I don't know, Helen, if you could touch on what we will be able to do within that. Obviously, we're hoping to streamline to avoid duplication, but there may still be some element of choice that we can offer people.
Yes, absolutely. And I think it's a very fair question and comment, because I know, looking at our existing data, that patients don't always access the nearest site. And sometimes that's because at subspecialty level, that very particular service is only available on one site, and you don't necessarily see that in the data. But sometimes it's just that our appointment processes are not that flexible, and we don't always talk to patients, frankly, about what's going to work best for them. So yes, it is absolutely part of our strategy. We're going to have an outpatient transformation programme. We're currently implementing a new electronic patient record that will go live before Christmas, and something that's called a patient portal will be implemented early in 2022, and that will give patients much more visibility and control over their appointments. So absolutely, we want to do that. We want to make the booking process more patient friendly, give you more opportunities to express a preference for whether it's face-to-face or virtual, which site, what time. It's easy to say and a little bit difficult to do, but the EPR and the patient portal and the outpatient transformation programme will all be trying to get to that point where patients have more choice. And yes, if it's more convenient for you to go to Watford than Hemel, even if you live in Hemel, then that should be possible, and vice versa.
Thank you, Helen. We have had a note from Edie to say that, you know, we were talking about making face-to-face appointments possible, and that she hasn't been offered that opportunity. And is that something that we think will be easier once we have EPR and the patient portal, and, you know, we're going to really revamp our booking system? So I know it's a bit difficult liaising with us around appointments at the moment. We don't make it as easy as we would like it to be. Do you think that that option for face-to-face is something that will come in the new year and we have better systems?
I'm not sure that particular issue is a systems issue. I think it's important to remember that COVID isn't finished yet. So when we talk about offering choice, that's, you know, absolutely in the future, we need to make sure that we're offering choice. And we need to make it clear to patients how they can express that choice. If our default at the moment is to offer a virtual appointment, what's the mechanism by which patients can request face-to-face? So we do need to work that through and make it work. At the moment, we are still using quite a lot of virtual appointments just because, you know, COVID is still here. We've still got some workforce challenges. We want to keep footfall on our hospital sites low. So I think it's worth having that in your minds. Having said which, Edie, if you want us to pick up and see if we can find out how you can articulate a preference for face-to-face right here and now, we could take that outside of the session. So that's my understanding, Louise, at the current time.
Okay, great, thank you. And just a reminder, if you have a question, if you send it to us via the chat function, and then we will come to you to ask if you want to ask it in person. So if you can put that in the chat function first, that would be great. Helen, I have a question for you on construction time, and it is just highlighting the difference between what you said earlier, which was a 3-year from the start of construction to new buildings being open, which is slightly different to what's in our outline planning application. And I'm not sure if that's, you know, taking into account enabling works or where the difference lies. I'm afraid I don't know who asked that question. So if I can just put that to you, Helen, and if the person who asked it isn't happy that we've covered it, then please do come back to us. So it's just the difference in construction times between the 3 years and the 5 years stated in the outline planning application. Thank you.
Yes, so I think you're right, Louise. It is what's the definition of construction start, and what does the whole programme look like end to end? And obviously at the moment it is all estimated, because until we've got an approved business case and a contractor and a definitive agreed timeline, it's difficult to say exactly. But the first thing that needs to happen is we need to relocate our pathology services, our oxygen, and some of our existing ward accommodation. And to enable that to happen, there's a few other moves that would need to happen. There's then a kind of groundworks phase where we need to get the land ready for what I call construction proper. So between those two things, enabling and groundworks, we think that is likely to take about 2 years in total. And then construction proper, where you've literally got the building starting to go up, is estimated to take between 2.5 to 3 years. And it may be quicker if progress is made with modern methods of construction, and that's confirmed as part of the programme. It may take a bit longer because it is a major construction programme, and until the contractor's on board, we can't say definitely. But yes, 5 years probably in total from the day we start the enabling works. But as I said earlier, we're hoping that we're going to be able to do enabling works in parallel with the business case process. So the 2023-24 construction start date is when you actually see the buildings go up.
Okay, great, thank you. I hope that's cleared things up. There's a really good question here about population. So I hope, Victor, you're happy with me putting this to Helen, but please indicate if you aren't. But it's about the plans that we are seeing from local councils, Helen, and Hertfordshire Council, for instance, are proposing to build nearly 3,000 homes in Bushey alone. And so the questioner asks if other councils in our area have similar building plans, will we be able to cope? And I guess it's useful to know the extent to which we look at these figures before we submit our outline building case. Thank you.
Thank you. So this is quite a complex question, but the answer is yes, we do look. We've looked at the Hertfordshire wide housing growth targets. We know where different areas of housing growth are expected to take place. We have reflected that into our business case modelling in terms of growth in demand. But equally, we look at how we expect services to change in the future and the delivery model to change in the future. So the strategy is to try and minimise admissions to hospital wherever possible. So if I answer this question framed around beds, it's not all about beds, but it tends to quite often be what's in people's mind when they ask the question about future growth and capacity. The ambition is to reduce the amount of to hospital and the length of stay through things like virtual hospitals. So again, some of you will have heard us talk about the COVID virtual hospital. Successfully looked after about 5,000 patients in their own home over the past year through COVID and prevented admissions and supported shorter length of stay. We are rolling that out now to heart disease conditions, and with digital technology, we think it's possible to quite significantly transform the way after people when they're unwell. So we take all of that into the balance as we then project what future capacity we need. We have allowed for some growth overall in terms of bed numbers and diagnostics and theatres in particular. Not as much as a straight line projection of population growth because it's offset by that transformation I've just described. But the other thing to note is that we are really aware of the need to have flexibility in our design and our future plans. We are expecting to retain some land for future development. We've even got a very, very draft kind of indicative drawing from our architects, which explains how we might be able to expand the buildings in the future under our preferred option.
Thank you. Can I ask you, Helen, a question about privatisation or different ways of providing services? So we know we have an ophthalmology service, or there is an ophthalmology service which is provided from the Intu Centre in Watford, and similarly I think in St Albans and Hemel Hempstead we have services that run from buildings other than the hospitals. Is that something that will increase as we move forward?
So I think the best way to answer this question is to talk about the West Hertfordshire Health and Care Partnership, which is part of the new, people probably familiar with the clinical commissioning group and the role of commissioners and the different providers and the way things have worked over 10, 15, 20 years now in the NHS. That is changing to a slightly different model, which brings provider organisations together with primary care to think about how we meet the needs of the population. So for our patch, that's ourselves, it's the Mental Health Trust, it's CLCH, which are the community provider, it's our GP colleagues, social services, and we're coming together to say, okay, how do we meet the needs of the population? And also who takes responsibility for which elements of care. There is, we need to be open-minded about who's best placed to deliver the best care for patients and what the right setting is for that care. I'm personally kind of quite agnostic on the subject of primary care, independent sector organisations, as long as they've got a good skill set and they work collaboratively and we join care up for patients. Honestly, I think that's the most important thing. Most of the organisations that are delivering care locally at the moment are either NHS organisations or primary care organisations with primary care contracts. There are very few kind of pure commercial models, but there are some, and as long as they're delivering good quality care, that's what counts. I don't expect it to increase. Actually, I expect it probably to slightly decrease over time as we develop new partnership models. But that's for the Health and Care Partnership to determine. It's not for the trust to determine.
Thank you, Helen. Just a quick reminder that if you do have a question, if you can just drop it to us in the chat function, and then we will come to you to ask if you want to ask that in person. So if you can just let us know, it's just so we've got an idea of what's coming in, so that we can group them if we need to. We've got a really good one here, Helen, about building supplies, and we know that this is a bit of an issue at the moment. So just want the person asking the question just wants to know if we've factored in some of the difficulties with supply of building materials, but also the increased costs, and whether these issues will be taken into consideration.
So obviously building supplies is a really live issue at the moment, with a combination of COVID and Brexit type issues kind of coming into play. And we'll have to hope that by the time we get to construction, some of those issues have been worked through. But actually the main answer I want to give to this is that the new hospital programme are leading the development of a commercial strategy and working really closely with the market on how do we make sure that we're able to build hospitals. On the cost issue, yes, we have to factor in inflation. Building cost inflation, is quite high, higher than other sorts of inflation. That may increase further, at which point the Treasury are going to have to fund it. It's going to have to be funded. It's kind of not so much in our local control. Louise, I'm just going to say something here because I've seen a little bit of chat on the system, and I think it's our friend Steve from Herts Valley Hospital saying he doesn't want to be sensitive. He wants to ask his question properly in person. So just Steve to say, people are welcome to ask their questions in person, and if you feel strongly that you want to do that, then let us know. But it's helpful to know what the topic is so that we can pull it in at the right point. But Louise, I'm going to go back to you. It's just in case you hadn't noticed that Steve was feeling a bit frustrated, let's say, about that.
Yes, I do realise, but I'm just trying to be fair, because other people are sort of sending in their questions and indicating if they want to ask in person. So just out of fairness to everyone else who is using the chat function, if Steve, please just do that, and we will come to you shortly. So we have just got over 10 minutes left, and I have a question which Jenny wants to ask, which is about lung function and echo. Jenny, I hope we'll do our best at answering it, but please, if you want to, we'll make sure that your camera is on and you're unmuted, Jenny. So if you want to go ahead as soon as you've done that and ask your question. Thank you.
Okay, thank you very much, Louise. Yeah, it's a question. I only know about these two because they've applied to me, and I'm sure there are others. There are certain tests that people have which involve very skilled technicians. I was in the A&E in February, and as a result of that, I had a CT scan, and as a continuation of that, I then had an echo appointment, which was done fairly quickly and very, very efficiently. However, I heard nothing back from that. Fortunately, it wasn't crucial. However, I did have an appointment 2 weeks ago, for example, for a lung function test, which again was done by a technician. I would like to know why there are such long delays, because apparently neither my GP nor I have had any feedback. Sorry, my breath. From that lung function test, and I know they have to go from the technician to a consultant or whatever to be looked at. But I think it's important that patients know what has happened to their test, whether or not they need to have any further action or for any further appointments. So there are long delays. I don't know. I mean, the lung function and the echo one I only got because I actually got the hospital to send it to my GP over a month later because they hadn't heard either. So is there any reason why there's such a long delay? We're talking about having this sort of rapid movement from one area to another, but you have a lung function test, then you go home. It might be a long way away. You might live the other side of St Albans and a lung function test. And you have then got to go back. Okay, I'm sure that has to happen because it's quite a complicated piece of work, but I am concerned about the long delays before people know the results of tests they've had. Thank you very much.
Yeah, so I completely agree, Jenny, that communication, letting people know the results of tests is really important. And sometimes it does take a bit of time because, as you say, they have to be reviewed by a senior consultant and a plan made. We don't always get it right. Some things do slip through at the moment. The electronic patient record should absolutely help with that, and the patient portal that I've just described, because through the patient portal you'll be able to access your own test results. So I agree. If you've had tests on an emergency care pathway, I think the process to make sure patients hear the outcome of those tests, particularly if they're not admitted, probably doesn't always kind of follow through in quite the same way that a GP referral planned care test would do. And I think that's just volume and complexity there. But if you've got specific concerns that you want us to pick up outside of this meeting and like us to follow up for you to find out where your test results are, we can try to do that. But suffice to say, I agree it's important, and hopefully electronic patient record will help us with this as well.
Thank you very much. Thank you.
Thank you, Helen. Kumar, you have asked a question about population and East and North Herts. I couldn't quite get to the nub of it, but I'm very glad that you want to ask it in person. So we're just going to make sure that you're unmuted so that you can go ahead and do that. So over to you, Kumar.
Thank you. I'll simplify the question. Thank you for allowing me to ask the question. Really focusing on the one-stop shop concept, which is a very strong concept, very valuable concept. The question simply, leaving the population aside, simply being, clearly you cannot, and I imagine you're not including in the strategic outline case, the possibility of the WHHT being able to address every conceivable clinical condition, pathway for clinical condition being addressed by that one-stop facility within WHHT. And within our ICP, there are several other esteemed, let me put it that way, institutions, hospitals, such as Eastern North Herts and West Essex. Now, are you already taking into account, or have been forced to take into account, narrowing down the specialities that WHHT is going to concentrate on and build that into the SOC, and if that is the case, have you shared that widely with the populace so that the populace have a feel for what conditions that they can access at their doorstep and what conditions that they need to go a little bit further to access? I tried to simplify the question a little bit. I hope it came across better. Thank you.
I've got the gist of it, I think, Kumar. So I'm just going to pick you up on language a little bit because you used the word forced. And I'd say absolutely, we're not being forced to do anything. We talk to each other, we talk to our partners, we've talked to East and North Herts Trust to say, where do we think we're strong in service delivery, where we might be able to support them? Where do they think they're strong in service delivery? Are there areas where we think we would benefit from support? And it's all really about getting the best clinical care for local residents. And sometimes it doesn't make sense for every hospital to do everything. But we have a duty to engage, and we would absolutely be engaging and talking about that as and when plans might come forward. At the moment, the only ones that are confirmed is the work around vascular that everybody should be familiar with. There might be some more coming through. Our clinical strategy actually says a bit more about this, and where we think there might be some benefits to having a look across a broader geography. But in terms of the redevelopment, we're trying to keep our plans flexible, and there may be some small changes to different specialties, but not not substantive changes to what we would need to build off the back of that. Does that answer your question, Kumar? Is that okay?
Yeah, broadly, I think, thank you for that answer. Broadly, I think it answers. I think what you didn't say, that the minutiae, the slight flexing as and when the needs changes, and the changes to the planning and outline case, you didn't say that you will continuously engage with the public and ensure that the public's buy-in is as strong as it is for the initial outline case.
Yeah, well, we need to keep, obviously, absolutely, we need to do that. It's quite tricky and challenging sometimes when the rules of the game are not always completely clear to us locally. But yes, we will continue to engage, and we've got plans to do that. So I'm conscious that we're nearly out of time, Louise, but I think Steve is actually going to pop if we don't let him ask his question. So how are we doing with other questions? I'm happy to go a little bit longer if other people are. Oh, are you still there, Louise?
I am, sorry, yes. There are a couple more. Edie has an interesting point that we should probably touch on about how we run the meetings. So I'd be interested in hearing that. I don't know what Steve's question is because you haven't committed it to the chat, Steve, but Helen, if you're happy to go to Steve, we've got a couple of minutes, so let's do that now, I would suggest.
Let's take oh, well, Edie's is about the running of the meeting, is it? All right, so Steve, what is your question? And try to keep it brief because we are nearly out of time, and if necessary, I'll pick up an answer with you outside as well.
Right, so thanks for letting me ask the question. I refuse to put it in writing in detail to be censored. That's my only issue, Helen. So I'm going to get to the point. The snazzy graphic that you produced last month states that the facilities will be opening 2026/28, but today you've said it's now 2027/28. So it's clear that the government and the new hospital programme have been affecting the timeline, and quite rightly you've been insisting on commonality for design and things like that. But the elephant in the room is still that the Trust has excluded clear sites because of time constraints that are now irrelevant, and the SOC is irrelevant as well. So the Trust cannot demonstrate best use of public funds, where a shortlist has been directed by the Department of Health and Social Care and is based on irrelevant, out-of-date criteria. The Treasury will be bonkers to approve a scheme without being able to see the best use of public funds. So why do you insist on pursuing a scheme without widespread public support and without any way to demonstrate best use of public funds? Thank you.
Okay, thank you, Steve. So our view remains that the fastest route to new and improved facilities is to redevelop on our 3 hospital sites. And yes, the overall timeline has moved back from the original new health infrastructure programme, deliver as close as possible to 2025, but the mandate is still deliver as quickly as you can. And we were always clear as a board that speed was a key factor, and deliverability, so certainty of deliverability, was a key factor. I know we hold different views on this, Steve. I respect your view. I know you feel very passionately about it. But the truth is, we don't have an identified alternative site. It would take months, if not years, to work through all of the different issues associated with feasibility studies, commercial purchase, etc. And I have no doubt in my mind that it would be a longer process. significantly to get to that point. And that is the position of the board and the CCG. I know that people who believe passionately in favour of a new hospital on a new site think it could be done more quickly. They think it could be done more cheaply. You know, our view remains that the right, you know, the fastest route to new and improved facilities is our 3-site strategy. And I think we don't believe that there is any cause to revisit our shortlist. Ultimately, you may be right that the Treasury may say no. We don't believe that's the case. We've debated this with Department of Health, new hospital programme, regulators. We have not been instructed to review or revisit the decision to not include any new site options.
Can I just come back on that briefly?
Very briefly.
So I get what you're saying. You're putting all your eggs in one basket, but wouldn't it be an absolute tragedy if down the road your plan is refused and you haven't got a plan B? If it comes out that after a detailed investigation, not a 45-minute phone call with the landowner of a site in Chiswell Green, that actually it would cost more, or it would take longer, or it would do whatever, then I'm the first person to go, okay, we made the right decision, but we haven't actually done that assessment. And the site review was so brief, it was just, you know, lip service. So surely for everybody in the area, you want to make sure you've got a plan B and you're making the best use of funds. And you've just said you haven't done that.
I haven't said that. I haven't actually said that, Steve. But look, we're not going to agree on this. So, you know, we have a range of options that we are assessing. We have been through an appropriate process. We have discussed those options with new hospital programme and DHSC. They're satisfied they're an appropriate set of options for us to include within the outline business case. We want to put our energy into delivering the solution on our 3 sites, and the amount of time, energy, cost that would go into trying to identify alternative sites would be disproportionate, and that's our view and remains our view. I know not everybody agrees with us, but that's the position. So, Louise, shall we go?
Yes, please.
Yes. Shall we go to Edie and get her reflections on?
Yes, I think that would be good, because we're always looking if there are ways that we can improve or make these meetings better. So I don't know, Edie, it's probably easier if you're happy to explain your question to us, or your point to us, if that's all right. We'll just unmute you. So, Priya, can I just ask that Edie is unmuted, or that Edie, you should be able to do that yourself now? Thank you.
I have now, thank you. It's just that I went to a meeting yesterday, attended a meeting run by the partnership, the South and West Herts Health and Care Partnership, and it was run quite differently. And I thought it was quite interesting, because at the end of it, I felt more included. It was much more inclusive, because you didn't have to use the chat at all. You could just ask a question. And also they broke up into groups, and breakout groups, small groups, where we could discuss things and then come back to report back. And I thought that was a much better way of going about things, because today I feel I've been talked at, but not really included.
Okay, well, we're sorry to hear that, because we did try to allow time for questions, but your comment about breakout rooms is really interesting, and we have used that before. You know, we use it as colleagues when we're discussing topics, and we've all done that with various engagement meetings. So it's absolutely something that we could do. So thank you. I don't think there's any reason why we wouldn't do that. We probably need to find the right topic to do it, but absolutely, yeah, we can do that. Promise you we will.
Yeah.
Thank you.
Can I just comment as well, Louise, on that? So thanks, Edie. I don't disagree. I think so. Today, I think we were clear at the beginning of the session that this was mostly an update. So this was mostly us giving you information and then giving you an opportunity to ask questions. I do understand that we've done quite a lot of that. And unfortunately, it's slightly the nature of this process that things move around and people want to just understand. Genuinely talking to people about, well, how do you think we could solve the travel and access issues, or how do you think we could be addressing this, is a different kind of session. And I agree we should be trying to do more of that. I'm going to be honest and say one of the challenges for us with this particular programme of work is we do struggle to get past the difference of views around new sites. So if we have a completely open discussion, I'm just going to say it like I see it, the voices that tend to dominate are the Steves and the new hospital saying, but you're making a horrible mistake. And sometimes we're just really keen to sometimes talk about other things, but we find it hard to make that happen when we have a completely open, unfettered. But I do accept the point that I hate feeling talked at myself. So maybe we need to have some sort of terms of engagement which says this is genuinely what we're going to talk about today, and can we agree to not talk about some other things, because then I think we will achieve a more open dialogue and a slightly freer, feel able to have a slightly freer and more open kind of approach to questions and group work. It's hard to do it at the moment when we're constantly kind of debating the same point about, well, haven't you made a terrible decision, Helen? So I'm just being honest there, Edie, but I'm really keen that we do. And I felt that at points over the last few months, we have managed to have more inclusive, engaged discussions around, well, what is the right clinical model and how would virtual appointments work and how can we improve choice and what is the right model of care. So that's my honest response, but Edie, but I'm grateful.
I can't remember a meeting like that I've been to be quite honest. And you anyway are always going to be in control. You control what happens. You know, you can stop somebody talking, can't you? Just mute them.
Can, but that wouldn't be ideal either, would it, Edie? So I take your point. It's fair feedback. We will reflect on it, and we will think about how we can do some of those things that you've described. I'd be really helpful, not now because we are out of time. We've let this run over, but if other colleagues who have dialed in today have got any perspectives on that, what we've just debated, we would really welcome your views on that.
Thank you, Helen. I can see, sorry, Kenneth, you've got your hand up. We're literally running out of time, but if it's very, very, very quick, did you want to just mention something briefly? If we will unmute you. You should be able to unmute yourself. And if it's not working, I don't have anything. There you go, Kenneth. Yeah, if you can be very brief, please.
With the reorganisation going on at Mount Vernon, do we plan to take over some of the cancer treatment at West Herts?
I would say, just in the interest of time, that we do cover this in our A to Z. So if you were to look on our website, you will find information about how the services will work. The short answer is no, but there will be more detail on this, and much more detail as the Mount Vernon project moves further forward. So in a short answer, it's no, but please look on our A to Z, which is on our website, and it sets the situation out more clearly. In wrapping up, I would remind you that if you want to send us a question that you think should be in our update film, please do so. But please do remember that we are trying, as Helen says, to move forward, and that will be the nature of the very short film that we're making. So without further ado, unless you have anything else to add, Helen, I will say thank you, everyone. Thank you for your time. Sorry we ran over, and we will think about doing the meetings in a different way in future. So thank you, Edie, for that. Noted. Bye-bye, everyone.